Welcome to the American Public Health Association webinar titled Reproductive Rights and Justice, Where Do We Go From Here? This webinar is being hosted as part of APHA's 150th anniversary celebration and a month of activities examining the root causes of health. I'm Regina Mahone, your moderator for today's discussion. I work as a senior editor at The Nation, a print magazine that has been around since 1865. Our independent journalism speaks truth to power to build a more just society. At The Nation, we recently launched a free monthly newsletter called Repro Nation, where you can find all of our most recent reporting on reproductive rights, as well as links to resources for anyone seeking an abortion in the United States. According to a new analysis from the Guttmacher Institute, at least 43 abortion clinics across 11 states have closed since the Dobbs ruling. As more states ban abortion in the coming weeks and months, we can expect that number to grow. And as someone like all of you who looks at the Dobbs ruling overturning the constitutional right to abortion as a healthcare crisis, I'm so glad to be here to hear from our phenomenal panelists about the role we can all play in increasing access to information and resources for people seeking abortions. Before we get started, some housekeeping notes. Today's webinar will be recorded and posted to APHA Now, a digital library of events, continuing education offerings, and more. When you have a moment, please check out other recordings from this year's 150th anniversary, which are all available for free. You can also find and purchase recordings from APHA's Policy Action Institute and content for continuing education credits. We will be taking questions from the audience during today's event. You can type your question into the chat box to the right of the video player at any time throughout the program. But we will take questions toward the end of the presentation. We also encourage you to use the chat box to introduce yourself to the other attendees. All right, let's get started. It is my pleasure to introduce Gerald Hayes. Gerald has focused her legal career on social justice and gender equity with specific expertise in reproductive health, rights, and justice issues. She currently serves as the Movement Building Director at If, When, How, Lawyering for Reproductive Justice, where her role is to shape movement building strategies, grow and evolve programs, and oversee the mobilization and networking of law students and legal professionals to champion reproductive justice within and beyond the legal system. Gerald has previously worked on federal reproductive health rights and justice policy for Physicians for Reproductive Health, Advocates for Youth, and the Black Women's Health Imperative, and has served in a leadership role at the DC Abortion Fund and the Women's Information Network. Benny Del Castillo. Benny is the current board president for the DC Abortion Fund. She became part of the DCAF community in 2014 as a case manager on the Spanish line. Abortion access work is heart work for Benny. In her daytime job, she is a trauma therapist. Haley McMahon. Haley is a public health researcher and reproductive justice advocate who works on structural and social determinants of abortion access in the United States. She is a doctoral student at the Emory Rollins School of Public Health and a board member of the Holler Health Justice, an abortion fund serving Appalachia. All right, well, thank you all for being here. Gerald, we're gonna start with you. Given what we saw in Kansas last night, this seems like the perfect place to start. Why do local elections matter for reproductive justice?
One, thank you all for allowing us to take part in this important conversation with you all. So one of the things that we know is politics is local, where people live and how their government works in their local jurisdictions is important. And that's why elections matter. It's why it's important for us to be engaged as part of the political process, because so many more of our rights are being determined by politics, by changes in legislation, by how the law is being used, both, in some ways as a tool of oppression, and in other ways as a source of liberation. And so what we saw in Kansas last night was the political process working in a way when people show up and people, show where their values are and what they support, we can see growth and movement. We can see shifts and changes in a positive direction. And that's exactly what we saw happening in Kansas. There are other ballot initiatives that are being proposed that are, essentially putting our rights on the ballots. And this is why it is so important for us to stay engaged in this process, to not give up hope, and to help our internal optimists stay optimistic, because what we are going to need is that sustained focus on this issue. It is the sort of thing where, the overturning of Roe was 49 years in the making. And so the solutions are not going to happen overnight, but it is going to take sustained effort on our part. This is the sort of thing where it can't be, this just can't be something like we focus on, in the short term and then kind of let it fade back. We have to stay resilient. We have to stay engaged and motivated to continue to show up. And one of those ways that we can keep showing up is making sure that we are focused on our local, state, and national elections, making sure that we are educating ourselves on the candidates and educating ourselves on the issues so that we can make informed decisions, so that we are also encouraging other people in our lives to be active in the political process, so that we keep this democratic process that we have available to us and push to make changes to reinforce our rights, to push back against further attempts to restrict our rights.
Great. And so now we have a question for everyone. We'll start with you, Gerald, and then go to Benny and Haley. So APHA is a longtime supporter of policies that advance reproductive rights, and members of the public health field have championed access to services through the promotion of the Affordable Care Act, Title X family planning clinics, and preventive health services. Now that we are facing a political climate that makes policy solutions to abortion access more challenging, how can public health practitioners adopt a reproductive justice approach to better support the reproductive health of people of color and address systemic barriers to reproductive health right now? And I know that's a big question. So we'll start with you, Gerald, and then again, we'll go to Benny and then Haley.
So one of the things that I think is really important is that people understand when we're talking about reproductive justice, what we're really talking about. And the reproductive justice framework was a framework that was developed specifically by women of color and Black women to address the intersectional aspects of their identity and the ways that they were experiencing oppression in multiple ways. And so understanding, just as you mentioned, the racial components that can impact ability to access care, the socioeconomic components that can restrict access, all of those different systems of oppression, recognizing that decisions that are being made by individuals aren't happening in a vacuum and aren't happening based on just one identity that they have. And so solutions to many of our issues are interconnected, and it's understanding the interlocking systems of oppression at work, and that we have to be thinking more broad. We cannot silo abortion or other reproductive health needs out from the broader health perspective. So if we're talking about health, we have to include reproductive health. And we have to understand that, race is a part of this. So if you're talking about reproductive justice, you can't be talking about reproductive justice if you're not including a racial analysis, because that impacts the way that people are able to get care. It speaks to the different barriers that people have in sort of accessing care across the board, not just related to reproductive health care, but healthcare in general. And so when we are thinking about solutions, when we are thinking about how do we work towards the visions that we have for broader public health, we have to include analysis around what are those, and be real about what are those barriers that people are experiencing. One of the things I want to note about the Roe decision and the sort of overturning, we have many communities who have long been facing what the reality is, that just having a legal right to something is not sufficient, that we have to also be thinking about access. What does it look like for people to actually access the healthcare that they need? And that's beyond just the legal right. That is looking at the economic situation. Do people have the resources to get the care that they need? Do people have, the other systems that are the other economic systems? Do they have access to jobs with livable wages? Do their jobs provide, sick leave? Do they have the ability to take care of themselves and not have to worry about their economic security? So we have to be thinking about these issues from looking at the different systems that are happening, and recognizing that, folks are experts in their own lives. Folks have real lived experience and understand how to get care. They just need access to the resources. They need access to, we recognize that clinic-based abortion is something that there is less access to because of the restrictions that have been happening for the last 30 years, not just, in the last year. And so people are looking to things like self-managed abortion as a way of making sure that they are able to get what they need. They are looking to abortion funds, which have long been in the space, providing resources to folks, helping logistically people get access to the care that they need. And so we have, we know what is needed. We just need to be looking at making sure people have access to those resources, and again, paying attention to those bigger systems, recognizing none of these decisions are happening in a vacuum. People are living, are making decisions based on a full range of factors. And so the more that we can acknowledge and identify those bigger systems at play, that helps the solutions be multi-pronged, and making sure that we are looking at the full range of people's lived experiences.
Absolutely. Gerald, you mentioned, abortion funds, and Benny, if you'd like to chime in on, that RJ approach, which is, abortion funds are very much rooted in the reproductive justice framework, how public health practitioners can uplift that in this moment.
Yeah, absolutely. And first, thank you, Daryl, for highlighting that abortion access is one point under the umbrella of reproductive justice, right? So if we want to learn the history, right, in like 1994, it was 12 Black women and femmes who coined that term and really developed that framework. And that's important because it also posits other points. So for example, it posits the fact that every pregnant person should have the right to birth in a manner that they wish, in the space that they wish, at any age that they wish, which this kind of pushes against some of our biases. It also posits, again, right, that right to access contraceptives, the right to access and be able to end a pregnancy, if folks would choose to. It also posits the fact that we can separate reproduction from sex, right? And the last one, and this is, I think, one that Gerald really was honing in on, and it's so critical, is that people have the right to parent the children they have without fearing violence from the government or other individuals, right? And so when we're talking about reproductive justice, it includes all of that. Right? So I'm the first person, even though I'm the board president of an abortion fund, to say abortion funds touch one point of that, right? Our vision is reproductive justice, but we really focus on abortion access. The reason I want to differentiate is because it is no coincidence. It is no coincidence that the folks who are being impacted the most, and it's okay to name that, are poor people, Black people, brown people, indigenous people, trans people, non-binary folks. Like, we should really be able to name that because it is made that way, right? So a lot of the quote unquote pro-life movement, what we would like to call anti-choice movement, it is actually not about life. I really like to talk about it as power and control, right? And so what abortion bans have been doing, and what we're seeing right now, is folks who are already on the margins, systemically, intentionally oppressed, are really seeing the impact even further, right? That, again, has been designed that way. Because prior to June 24th and the overturning of Roe v. Wade, the DC Abortion Fund, and I can confidently say other funds, have been seeing people have to cross borders, have been seeing people have to weigh their options of, well, I don't have childcare. I have zero money to pay for transportation. I have zero money to pay for food. Oh, it's a multi-day procedure. I need a hotel. I have zero money to pay for that, right? Like, that is not new. That's been happening for as long as, and I'll speak for the DC Abortion Fund, for its 27-year history. We have seen folks having to come to our area in order to access an abortion from New York, New Jersey, Ohio, Pennsylvania, Delaware, Connecticut, Florida, Georgia, Alabama, Texas, West Virginia, all over. And what we're seeing now is that's only increasing. So I think a great first step for any person, especially those in the public health field, is to acknowledge that this is not new. This has been happening. And also to acknowledge that it is very much designed this way, right? Much like Gerald said, like, Roe v. Wade never guaranteed access. Perhaps if you were a wealthy, cis, white woman, perhaps, but it never guaranteed access. And I think there's power in recognizing, hey, we can then, if we're aware that this is nothing new, if we're aware that this is intentionally made, then we can intentionally dismantle that, right? When we're in front of a patient, when we're in front of a friend, when we're in front of a neighbor, when we're in front of any person talking on abortion access, we can bring in all of these intersections. How the fight for someone to access their abortion, because it is quite literally a fight right now, is different for example, a white cis woman than a disabled Black trans woman. Because there's many intersections of our lives that constantly are ramming into each other because we don't live one-dimensional lives. And every single person who is responsible for the overturning, and even before then, because abortion bans have been happening way before June 24th, every person is aware how in this country, because of racism and classism and homophobia and transphobia, and the history of colonization, they are aware that folks with those identities that are marginalized and oppressed, it's going to be harder for them. They're very much aware. And so once we also invite our awareness into it, that's how I believe we can take a step forward and we can reinvent what access should have looked like, right? And join folks, because I also want to note, this is, again, nothing new. Specifically, again, because of the reproductive justice framework, this is labor that has been taken on predominantly by Black women and femmes. And I just want to super highlight, because there's no need to reinvent the wheel. The wheel has been invented. We can join and keep it going. But I think those for me are the first two steps, is the awareness.
Thank you so much, Benny. I'm glad that you brought into the conversation the history, and as Gerald did, of the framework, of the intersections, that, abortion is part of this bigger framework. Haley, would you like to jump in and add anything in addition about, how public health practitioners can adopt this RJ approach in their work?
Sure. Yeah, I just want to reiterate something Gerald said, because I think it's really, really important. We as public health practitioners have a responsibility to acknowledge that lived experience is a type of expertise, and our technical expertise is not more important than lived experience. These are, two different methods that we can use to work on problems, but lived experience is very, very important. There is no amount of study that will ever get you to fully understanding what the experience is of driving from Louisiana to Virginia to get an abortion, and being a Black woman who has to face various hoops to jump through purely because of systemic racism. So I really want public health professionals to understand that lived experience truly is a type of expertise. And the other thing that I think we really have to acknowledge when we're thinking about this through a reproductive justice framework is that these bans are rooted in white supremacy. I think a lot of times our first inclination is to point only to misogyny, but these bans are rooted in white supremacy, and they long have been. And just as Benny was touching on, the people who are enacting these bans know who is most impacted by them. They know who is most disempowered by them. And so we have this long history of white supremacy, and it's not difficult to find. You know, we hear the same people who push for these bans. We hear them talking about the domestic supply of infants. We hear them talking about there's not enough white babies. We hear them talking about great replacement theory. There is a line of white supremacy that goes through all of this. And that is where it all comes back in this abortion ban. And I really want folks to understand that, because when we point just to misogyny and we aren't also looking at white supremacy and systemic racism, we are missing the forest for the trees. And so we really, really have to understand that. And in that same frame, we have to understand that criminalization is the biggest risk right now for people who are having abortions, people who are self-managing their abortions, people who are providing abortions. I think, you know, a lot of people's jerk reaction was to jump back to sort of the pre-Roe days and talk about this sort of coat hanger imagery and unsafe abortions. And that is just unlikely to be what the post-Roe era that we're now in looks like. And we haven't seen that happen yet. And it's unlikely that we will see widespread unsafe abortion because of the changes in methods and access that people have now. That's not to say it will never happen, but we don't expect it to be a broad pattern. So the big risk to people now is criminalization. And we have to think about that in the context of our racist carceral system. We have to think about that. And, you know, with criminalization being this huge risk, we have to, again, come back to Black and brown folks are taking on the greatest risk. They are who are going to be targeted by the carceral system. They're who has always been targeted by the carceral system. So there really, again, is just this line of white supremacy that flows through all of this. And we really have to understand that to be able to engage with it fully.
Thank you. Thank you for bringing that, Haley. And I want to talk more about it, actually, because you brought up criminalization. You know, the next question is around, you know, talking more about some of the key issues in public health that overlap with the reproductive justice framework. Abortion is just one way that people are being and have been criminalized in the public health system. But there are other ways that people have been criminalized in the public health system. So if you would like to talk more about that, or just other ways that you know, people overlook the other areas of reproductive justice as it overlaps with public health.
Yeah, I think there is a really big connection between the criminalization of abortion and the criminalization of miscarriage and stillbirth, because that has been happening for a long time. And it has primarily, again, been Black and brown folks. There are folks who are criminalized for anything that goes wrong in their pregnancy. They're blamed for it. And you know, they have documented well over 1,000 cases of this happening. It's not a very rare instance. And it's often healthcare workers who do the reporting. So that is something I also think we have to talk about, the child welfare system. And I think Dorothy Roberts is a great place to go if you want to learn more about that. Shattered Bonds is great. She also just came out with a new book that is also about the system. I think we have to talk about that, because that has historically been used to break up Black and brown families, often just for living in poverty. I think we often think about it as being a system that sort of breaks up sort of physical and psychological violence. But a lot of times it is purely just not having the resources to fully, you know, feed and clothe and shelter children, which there are so many other ways that public health workers, you know, foster care system workers, child welfare workers, all of us, you know, kind of in this sort of sphere of wellness and health, could not participate in that carceral system. And so I do want to think about that as a form of punishment and as a form of the way that Black and brown folks have been criminalized for reproduction, for different ways, different reproductive choices. So you're being banned from being able to end a pregnancy. You're being banned from being able to parent. A lot of folks are, pushed into getting birth control methods sometimes. So there are all these different ways that Black and Brown folks are having their autonomy taken away, their reproductive autonomy. And that criminalization piece is just so important, because it really does bring in all of these different systems that are changing the availability of autonomous options for Black and Brown folks. And again, it's, we've seen people already be criminalized for self-managed abortion. There have been at least 24 arrests already. So this has already been happening. We only expect it to worsen. And again, it's gonna be, and has been, Black and Brown folks who have been arrested. And it has been healthcare workers who reported them, the majority of them. So we definitely need to talk about, why are people reporting their patients? You're not obligated to, you're not required to. Why is it being done? You're participating in the carceral system in that way, and you're choosing to do it in that way. So we really need to talk about the sphere of criminalization and how we can disrupt it as healthcare workers, public health professionals. So that's really important.
Absolutely. The structural bias in our healthcare system that leads healthcare workers to report some parents, but not other parents, and the impact it can have not only on, Black communities, but also undocumented communities when people are then funneled into the immigration system if they're being reported on for their miscarriages and things like that. So the extent of this goes so well beyond, domestic, problems and the way that people are reporting. So I'm so glad you brought that up. We've been talking about the criminalization of poverty. So Benny, if you could speak a bit more in your work, especially at the abortion fund, though I know we all touch it in different ways. But Benny, if you could talk a bit more about the social economic barriers to abortion care and how being denied an abortion perpetuates health and other disparities.
Absolutely. I was actually at an event and I was recently asked, well, I get, travel and hotel, but why would people need help paying for an abortion? And I do want to say, blanket statement, we don't know what we don't know. So I'm actually glad this person asked me, and I'm happy to share more information. One is abortions are expensive. And I say that in the term of, if it is not free, I consider that expensive because it will be expensive to someone. So yes, I believe that all healthcare should be free and accessible. But what we're talking about is, often when I think of some folks who are like, yes, I believe folks should have access to abortion. And typically it comes with a, up to a certain point. Like, no one wants to have someone have an abortion in the third trimester. The reason I'm focusing in on this, because one, I do want to uplift that we all have bias and to kind of sit with that. But the fact that is we go further along the trimesters, after the first one, for example, the price increases like by the week, hundreds to thousands by the week. The other part is that a lot of folks are missing the connection of, again, seeing healthcare holistically. Like, a lot of folks that I speak to, because I still work on the lines, and for example, I specifically work on the Spanish line, which is not always, but a lot of folks living in poverty or below the poverty line. Some of them do not speak English. Some of them may be undocumented. And the trouble is they don't have access to any type of healthcare, right? And again, if folks do not have a primary care physician, do not have access to somewhere they can go for healthcare, then how would they be able to talk to a doctor about either certain symptoms, even obtain a pregnancy test, right? Like, all of those things are very much connected. And that's because everyone is often challenged by the fact of looking at healthcare, again, holistically, not just through one lens. So in terms of like criminalizing poverty, that is definitely one way, right? Like, the fact that people don't have access to healthcare, the fact that people don't even have a primary care physician, the fact that these same folks are probably Googling. And if we all Google, some of the first places to go are crisis pregnancy centers. Those are the first ones to pop up in Google if you're looking very, very quickly, right? So all of that is very much connected. What we see is often we never ask folks to tell us why, ever. That's ever, because it does not matter. But what we do find because of our society and socialization is folks are almost expecting it to be asked, and they tell us before. We even say like, hey, when's your appointment date, right? And what we often hear, and at least for DC Abortion Fund, is most folks we work with already have children, right? And a lot of what I heard verbatim is, I can't afford to have another child. And so those are just the realities. And that, again, I should say, is a societal, intentional barrier for folks, right? To Haley's point, and I'm so glad they brought up the criminalization, is we do criminalize poverty endlessly. And that's at the intersection of migration, neighborhoods, like all of that. The fact that people feel like they need to migrate to this country to escape poverty and then are separated from their children, like all of that is still very much connected. We criminalize certain parents, right? And so what we are seeing is when we ask folks, hey, just so we're on the same page, is there anything you can contribute to the cost? No is a perfectly okay answer. What they can contribute is zero. And that's to the cost, because again, the cost is rising. The most expensive abortion I've seen is over $16,000. Over $16,000, right? And that is even if there was, because there's a National Abortion Fund to assist, it's still, let's say, half of that. And at least our demographics for the DC Abortion Fund is quite reflective of the demographics of DC in general. Well, prior to the last census. So most of the folks that we're seeing calling us are predominantly Black or brown folks. And again, no coincidence to me.
And racism plays such an important part in all of this. So let's get into it. So APHA and communities across the country have been naming racism as a public health crisis, as it is. What structural barriers to abortion care, as Benny, you were just speaking about, what structural barriers to abortion care do public health practitioners need to remove in order to advance racial justice? And Gerald, we'll start with you.
Yeah, so this is one that Haley was speaking on earlier, which is the criminalization. And that is really, we want to be clear about with the legal risks and with the constitutional right sort of being done away with and it being returned to states. What is at risk is who is going to be criminalized for trying to access abortion care. And it's disproportionately people of color, it's disproportionately young people, it's disproportionately people whose immigration status may be at risk. And so, one of the things that we're recognizing is when access to clinics are being limited, as they have been since actually the Casey decision in 1992. That was this real decision that kind of started to gut the provisions of Roe. We've seen this increase in sort of the limitations on clinic-based abortion. And people still have the need to get abortion. Just because you make abortion inaccessible doesn't mean that it reduces the need for it. There are other measures that we should be doing when we think about public health, to that's making sure that people have the resources that they need. But what we're concerned about with the risk of criminalization is not just the actual criminalization that can happen in the moment, but the impact of that criminalization beyond just the actual incident. Even if somebody is criminalized and then is, a jury decides that they don't need to be punished, there is still there is still a residual risk of what that disruption to their livelihood might mean. Somebody might lose their job because of being criminalized, if they're not able to have access to bail funds to get out after they've been criminalized. What that does to their families, what that does to their livelihoods, what that could do to their future access to public health funds, for future access to support that they may need. And so this understanding, the link between our sort of criminal justice system and the ways that it has been used, specifically targeting Black and brown bodies, we have to acknowledge those connections. And I remember, sometimes people will say things like, oh, the system is broken, and recognizing, actually, no, the system's not broken. The system is working exactly as it was designed to, and really letting that sink in about the ways that these systems are rooted, as was mentioned before, are rooted in white supremacy, and that it's not a bug. That's the feature. That's the way that it was designed to work. And so we have to, when we are then thinking about the solutions, when we are thinking about, how do we address these, how do we address, issues related to criminalization, there are broader challenges, and wanting to put this into the broader perspective of the collective work we're doing around criminalization at large, around the carceral state. How are we pushing back against using risk of criminalization as that is the solution that many legislators are fighting. When you ask them what should happen to somebody if they need an abortion, and that the response is, well, they should be criminalized for it. What does that say about our society? That's the sort of way that people imagine this work to have, that's the solution, when instead we should be looking at, from a public health perspective, how are we working to address the specific needs, and how are we, to your question, how are we incorporating and understanding the role that race plays? And something that I have been taught, particularly by other medical professionals, is to remember that it's not race that's the issue, it's racism, and understanding the difference between saying that something is an issue of race versus racism, because we need to be really clear about who is in positions of power to be making decisions about how people are treated in their medical facilities. That it is not just somebody's race, that there's not like a biological, when we're specifically looking at something like maternal mortality, that's not specifically like, hey, people who are Black and brown are more likely because of their of their genetic makeup in terms of their race. It is, how are they treated at medical facilities? How are they, being responded to when they speak up about what their needs are? And remembering that people are experts in their own lives. People are experts in their own bodies. They, if somebody says something is wrong, that needs to be taken seriously, and it should not be discounted because of the color of their skin. So really understanding, the different ways that race can come in, and specifically the way that racism comes into play. And this is where we need to have more of these frank conversations. Talking about race can be challenging, and we still need to do it. That's part of the process, the discomfort that can come from talking about race and acknowledging it and still doing it anyways. We need to be more direct in these conversations, more explicit in talking about the links between racism and public health. And so, having discussions like this and understanding the broader context, understanding the history, understanding what patients come into a medical facility with, their lived experience, and having that respected, having their culture respected, having their perspectives respected, and understanding, the barriers that might be in place, for them to seek care. And so some of the ways that we need to do this is looking at what are our policies. Our, policies that we have at the federal level, at the state level, at local levels, policies aren't neutral, and we need to be real about the ways that policies can be disproportionately applied. And when we're advocating for particular legislation and policies, if that legislature doesn't include a racial analysis, doesn't include a real examination of what is the actual impact going to look like, we can miss opportunities to address past harms, to really look at what are the barriers that folks are facing. So we need to be looking at, when we're advocating, what's the racial analysis that is coming along with this? How are we specifically addressing past harms and the actual barriers? And part of that means we have to be talking to the people who are most harmed. We have to be, in our conversations about policy. These can't be made at just sort of high level without input from the communities who are most at risk. That's where the best solutions are going to come from, is from the people who are most, who are closest to the problem. And being able to hear from them specifically, what are you facing? So making sure that we are including the folks who are most impacted in our conversations, that we're not excluding them from tables, we're not excluding them from discussions, that they are more centralized in how we're talking about these issues, because that's how we're going to find solutions. That's how we're going to learn more about what is actually happening on the ground, what is actually happening in people's experiences when they're trying to access care. We can't just be thinking about that theoretically. We need to involve the folks and get insight on what's happening from the folks who are closest to the problem.
Absolutely. Thanks, Cheryl. Haley, do you want to add more on structural barriers that public health practitioners should be removing to advance racial justice?
Sure. And I think criminalization is definitely one of the biggest ones. I continue to be very shocked that we are not having a national conversation about decriminalizing pregnancy outcomes. Why is there not a national conversation about decriminalizing self-managed abortion, decriminalizing miscarriage, decriminalizing stillbirths, decriminalizing our general pregnancy outcomes? Because this is something that has been happening, and most experts expect it to worsen. So with criminalization being the biggest risk to most people in these cases, we really, really need to be talking about what a federal decriminalization law would look like and how it could be put into effect. I think something else that is very important for public health professionals to think about in helping folks navigate structural barriers and in dismantling those structural barriers is how we have sort of prenatal birth and postpartum supports and programs, and how this fits into local health department work, state health department work, whether it's things like helping folks access WIC, helping them understand how to enroll in Medicaid, helping them find a doula, helping them, get postpartum support. So I do think it's really important that we help folks who either would like to carry to term but have financial constraints, because that is, as Benny said, it's not important why people have abortions, but we do know from the research that financial reasons are a top reason that people have abortions. And there are many people whose pregnancies are not unwanted, they're mistimed. And so I think that's an important nuance to bring up. And in some cases, if folks had more social supports and more financial supports, they would be able to have a truly autonomous decision. And if they wanted to carry to term, they would have the support to do that. So I think it does look like a lot of investment in maternal and child health care, both for people who would rather carry to term and for people who are, unfortunately, are going to be forced to carry to term, because we know those people exist. And again, they are going to primarily be Black and Brown folks. So I do think there needs to be a lot of investment in maternal and child health, particularly because we've seen with Roe still standing that states that have many abortion restrictions also have the worst maternal and infant mortality rates. So we already know that's where it's happening. So I think there has to be a lot of investment in just general comprehensive poverty relief And we have to incorporate a race analysis and understand and center folks, Black and brown folks who have been pushed into poverty by systemic racism. So I do think there are a lot of ways that we can work on these social support systems and work against criminalization as our default, as Gerald was saying, as we kind of, it seems like a lot of, as they said, if your response to they had an abortion as well, they should be criminalized, then we have a problem. That entire framework is a problem. So I do think we need to invest in and expand in a lot of these support systems to more fully give folks reproductive justice, whether they want an abortion or whether they want to carry to term and parent. We need to have support systems for them. So I hope folks do understand that we do need a comprehensive system here to work towards reproductive justice.
Absolutely. And Benny, feel free to add more regarding efforts to advance racial justice that public health practitioners can take. I also want to bring in another question for you around how public health practitioners working on access to care can support abortion funds or help address the reason for abortion funds in the first place. You talked about this a little bit before, but this is all related in so many different ways.
Yeah, I think both Haley and Gerald covered all of it. I will say one thing I do want to uplift, and Gerald, I think, was touching upon of, we really want to bring voices of folks who are actually impacted to the table. Like right now, right? Like if we really thought about what this panel could look like, right? And to me, that's also tied into saviorism. And so I do just want to quickly highlight that in terms of every person here, myself included, has power in this room, and every person listening, right? The fact that people can tune in and have these conversations. And I think that's important to acknowledge when we're talking about how to really look at barriers. For example, what we've seen is a lot of healthcare professionals use that power when working directly with folks seeking abortion care, right? And I think that's the lack of acknowledgement of what we call service provider privilege, and the saviorism when it's not needed. Every person has survived every day of their lives without us. And so they will be okay. And I just wanted to uplift that. And thank you, Gerald, for bringing that to everyone's attention. To your question, Regina, of what folks can do is, and thank you for the way you phrased it, of the need for abortion funds, because you're right. Abortion funds should not exist. And I'll speak from my personal viewpoint, we should be actively working to one day not exist, actively, right? Because that's the whole point. And I think this was touched upon way at the beginning, that there's a difference between something being legal and accessible. And that difference, that gap, that huge, huge important gap is the reason abortion funds have had to exist. And right, because we come in when people are like, okay, legally I can obtain an abortion in DC. That is still true right now, but I can't pay for it. I can't travel there. And that gap is where we really want to focus on. Because when we close that gap, right, DCAF may not have to exist. All the other funds, which I adore and work very close with, may not have to exist. So when I talk about free abortions, I wasn't being funny. I wasn't being cheeky, no, it should be free healthcare, right? And abortion is part of that. So I think that's where I would love to see everyone, public health folks, healthcare folks, jump in and help us close that gap between legality and accessibility, because that's the issue. Right. And so when I talked about before about reinventing, for example, what Roe could look like, or let's name it something else, that's what I mean, is that it may have granted legality, but that meant nothing to people I talked to on the lines. It meant literally nothing, because they still could not access it if it wasn't for us. And that is not okay. To have people call absolute strangers asking for money is not okay. If we're saying we're the richest country in the world, we're the best country in the world, that should not be happening. And so I think I'd love for everyone to kind of be a collective in closing, again, that gap. And that can be, I'm a very literally what you can do. That can literally be having these conversations of legality versus accessibility. That can be talking to folks, if you do work in healthcare, about that very directly. And that means patients and coworkers and everyone involved. And that can be fighting for more, right? So I loved, anger is one of my favorite emotions, because anger tells us, this is therapist me coming out, anger tells us when something is wrong. Anger tells us this is not okay. And so I loved seeing people angry and expressing that anger in the overturning of Roe v. Wade. And I also want to say, there is so much more. We deserve so much more, because it did not do enough. And I think that's the biggest gap that I'd love for all of us to work together to close.
This is such a rich discussion, and I'm just going to say I have a couple more questions, and then we're going to switch to audience questions. So please, if you haven't already, definitely put your question in the chat box. So Haley, the questions for you, we're going to turn to disinformation. So both Public Health Authority and abortion access have come under a surge of political attacks recently and have been subject to disinformation campaigns. How can we unite to work toward our shared goals of promoting reproductive health and replacing misinformation with an understanding that abortion access is part of public health?
Yeah, it's a big question. I think we all need to talk about this, what it is. And I really loved that you started out the panel with this. This is a public health crisis. Abortion bans and abortion restrictions are a public health crisis. So we really have to talk about that and normalize it as a standard public health issue. It is something that we should be prioritizing. It touches every type of public health. It touches every type of bodily health. It is really, really, really a comprehensive issue that we have to prioritize in public health. So I think acknowledging that it is a very important issue, and also, say the word abortion. We don't have to always say reproductive rights, or a lot of politicians like a woman's right to choose. To choose what? What are you talking about? No, you can just say the word abortion. It's not icky. It's not a bad word. You can say it. Sometimes you're going to get some weird looks. That's okay. Sit with that discomfort and say it again. It's going to be okay. So I really, really, really encourage people to say abortion, make it normal in public health spaces. And we need better education for public health professionals about abortion. There are a lot of people who would consider themselves to be pro-choice and supportive of abortion who believe myths about abortion. Abortion is extremely safe. Abortion is extremely effective. We do not know of any long-term health effects. There are myths about breast cancer. There are myths about fertility. All of those are exactly that. They're myths. There's a myth that an abortion pill can be reversed. That's ridiculous. No, it cannot. There are all of these myths that have been very, very, very intentionally injected into our social consciousness about abortion. And a lot of us believe them, even though we are supportive of abortion. So I think we need more education for public health professionals about abortion and how abortion works, and and what all of the outcomes are for people, and what it means for public health that many states are banning abortion. We know from longitudinal data that being denied an abortion is terrible for individual health and for public health. It drastically increases the likelihood of poverty. It drastically increases the likelihood of having a chronic illness, of experiencing a pregnancy complication, of having children who don't meet developmental milestones, of having poor maternal bonding, of being connected to an abusive partner. There are all of these different kinds of negative health outcomes that result from being denied in abortion. And that, has been extensively studied by Diana Green Foster and her team at Answer. So we do know that this is very bad for public health, and people need to be able to talk about that as you would any other public health issue. if you feel like you can talk about COVID, you can also be able to talk about abortion in the same way that it is a threat to the public health of all of us to ban and restrict abortion access. So I do think folks need to, we need to be providing more education on this. I think it's really wonderful that a lot of public health schools do now have at least one course on abortion, which is really, really wonderful and really exciting for me personally. So I do think that's great, but we also just need to talk about it as a normal public health issue. It shouldn't be its own little side issue or a woman's issue, as a lot of people like to frame it, which is exclusive to trans and non-binary folks, just to mention that. It's not this little side issue, and that's actually what got us here. We have been sidelining abortion, as legal professionals, as public health professionals, as medical professionals, just as voters and people in general. We have been sidelining abortion for 49 years. We felt like it was safe, and it's been sort of siloed in its own little, be quiet, don't talk about it, don't say abortion. And by not prioritizing it, that is why we are here. As Daryl said, it's taken 49 years. It's been a long game. So we really, really have to talk about it and have to acknowledge it as normal. And, we really have to tear down some of that stigma. And I think talking about it also helps fight the disinformation, because when we as public health professionals are talking about it as a normal health issue as it is, we're talking about how it's safe, we're talking about how it's effective, how it's a normal pregnancy decision, normal pregnancy outcome. It's very common. 1 in 4 women will have an abortion in their lifetime. And it's believed to be even higher for trans and non-binary folks who can get pregnant. So it's very common. It's, a lot of people are having this experience in their life. And so we really have to be able to talk about it as we would talk about tobacco prevention or getting vaccinated for COVID or getting your flu shot. There are all of these very sort of normal, and we all have to write an essay about them at some point in our master's program, public health issues. And there's no reason for abortion to not be one of them. The fact that it's political, has been made political, doesn't matter. It is a public health issue, and we need to be talking about the facts about it. Regardless of what other people's opinions are, we have lots and lots of data, and we know what the facts are. And public health professionals need to be talking about it in that way, that, a lot of these beliefs are just not true. They're just not grounded in reality. If people believe them, fine, that's their prerogative. But as public health professionals, we need to talk about the facts of it, not about opinions and deciding that an opinion that is not rooted in fact is a valid view should not fly in public health between public health professionals. We should really be naming and calling out the disinformation. So it really is all about destigmatizing, about talking about it, and about being really educated about it, and doing some of the reading on it. And just, everyone can't be an expert on abortion, but just having a little bit of general knowledge about it and understanding how it touches your field of specialization, because I guarantee you that it does. So there is really just a lot of awareness and education and comfort, getting comfortable talking about it, that public health professionals can do.
Absolutely. We will switch to audience questions in just a minute. Haley, one more question for you. If you could just briefly talk a little bit about what the sexual and reproductive health section and other APHA sections are doing around abortion access currently.
Yeah, so we are, so I am with the abortion access, the abortion task force, and we've currently been trying to think about how sort of public health professionals who are practicing can really impact different types of access to reproductive care, and how public health professionals can be resources that have information about where to get an abortion, how to get an abortion, what are the resources for finding an abortion. That's something that we really, really would hope that health departments would be able to provide people. And Sarah Roberts has written a lot about this, and that is she and her team are a great place to go to learn more about what that actually looks like in practice. But it's, we're talking about how practitioners can play different roles in being able to help people get access to care and find care. We are also thinking about, what it looks like to, again, provide care for people who want to parent, to be able to provide post-abortion care for folks who may self-manage. It's also really important to think about, and this is something the task force has been talking about a lot, that a lot of APHA members, whether they're practitioners or clinicians, they are being threatened with criminalization. And so just as, as professionals and practitioners, obviously it's very important that the folks who have abortions are being criminalized. But when we're talking about, professionals, there is also a big risk to a lot of public health professionals. And so something we're talking about a lot in the task force is helping people understand that and sort of thinking about what sort of actions and strategies we can take to prevent that. So yes, we're talking a lot about ways to move forward with this and helping people protect themselves and understand the risks. And then also how, sort of just as practitioners and as public health professionals and as people who work with health departments can help support more of that poverty relief and maternal and child care.
Great, thank you. So first audience question, it's from Jennifer Warren, and I'm going to ask Benny to answer this one. So how do we address the mental health crisis that will evolve due to challenges in obtaining an abortion and forced pregnancy? Mental health resources are stretched as it is in our society.
Yeah, they are valid. To be honest, I think we haven't even seen the tip of this iceberg, as I would call it. So I shared with you all, I am a trauma therapist, and part of that is recognizing the intersectionality of abortion access or lack thereof. So we've talked about that a lot, but that is part of the ripple effect. So for example, when we're talking about the connection between abortion access or lack thereof and survivor justice, right? Survivors of sexual assault, for example. It is so connected in regards to consent and bodily autonomy and having control over one's body, and then having a country, a government tell you you don't have control over your body, right? Like those are inextricably linked. The same thing, even historically, and what we know by research is trauma stored in genes, like generationally. So if we think of this country's history of forced sterilization, right, on Indigenous folks, Brown folks, and Black people, that is still linked and it's still relevant, and it's, I would venture to say, another way that lack of abortion access, like that is exactly what it's replicating, right? So when we clutch our pearls, like this is not who we are, it is exactly who we are. It's exactly what this country has done, right? All of those are linked. I think what we will expect people to see is what we will expect within the mental health field is having folks really having to navigate maybe trauma, for example, that they haven't even realized may be coming up, either generationally, historically, finding that out, and also what that means in regards to people's bodies. And I focus on bodies because this is an attack on bodily autonomy, and that can come up many, many, many different ways, right? You have all heard us, all three of us talk repeatedly about intersectionality, racism, classism, homophobia, transphobia, and because it all connects to this. So for example, when I am in session, let's say with a non-binary person who has the ability to become pregnant, who may have had a child, and then hears this news and hears intentionally not being included in the conversation, that has an impact on their mental health, right? Like when people are intentionally excluding your existence, I would call that dehumanizing, right? That's one example that we will see. Others include, again, right, the history of having like, oh yeah, every single day I face racism, microaggressions, not so microaggressions. And then I have to sit with the fact that this country is once again telling me I have no control over this other area of my life, right? Like all of that does add to people's mental health and mental well-being in general. Again, I do want to highlight that when we're talking about healthcare, this is part of the conversation, mental health and mental well-being. And so what we will see, I don't believe is anything maybe new, but we will see it in larger numbers. For both ethical and just part of my job as a therapist, I have had to bring this news up, specifically June 24th and on, to check in with every single person. And what you see is it impacts people very, very differently, but it's all the same. And no matter how that person identified, right? And so what we want to do is, as always, and not to circle back once again, but we want to promote general access to healthcare, because that's what it is. Like mental health is part of that. And so that's what I will always advocate for. The fact that, again, people don't have access, meaning they can't pay for, they don't have insurance, so they can't get to see a therapist, that's also not okay. Right? The fact that the nonprofits have to exist to offer free, time-limited services is not okay. So I think that's also the big piece of it, is recognizing that it's also part of healthcare. And unfortunately, with how things stand, people don't have access to that either. But I think once we recognize those intersections, then we can get a little closer to what we're needing, what people are needing.
Great, thanks, Benny. Another question from JF Guider, and I will pose this to Gerald, but everyone feel free to jump in if you want to add some thoughts as well. But JF asks, BIPOC women understand the role of discrimination. So many white women do not. How do we shift this paradigm?
That's a really great question. And part of it is just like a real, to be honest, just being real with folks who aren't BIPOC, that for so long, BIPOC folks have been holding this space, have been noting that this was a challenge that was coming, have been coming up with solutions, things like abortion funds and the practical support networks and ways of getting people the support that they needed. Something we like to remind folks around self-managed abortion, that for as long as people have been able to get pregnant, people have been self-managing their abortions. Self-managed abortion is older than the practice of gynecology. And so we've taken care, we've figured out ways to take care of our needs for a long time. That has just been a part of the experience of what it means to be a person of color in this country. That has been part of the process, is learning how to survive, learning how to find strategies that may not be mainstream, that may not be as well resourced, but figuring out how do we take care of each other's. So we're tired. Been doing this work for a long time, and what we need, from our non-BIPOC folks, is that recognition of the work that has been done in these spaces, and the work that we need other folks to do with themselves, right? Like we're happy to support in some ways, but we can talk to our communities, but we can't talk to white communities in the same way that white people can talk to each other. And so that's a place where we need white folks to really step into their power and acknowledge and recognize, yes, this is going to be uncomfortable. It is uncomfortable to talk about race. That's how white supremacy was designed and set up. It was meant to feel uncomfortable so that you wouldn't talk about it. Like that's part of the design. And so you have to actively recheck that and think about being anti-racist as a muscle that you have to continually exercise. And in the same way that we do for our physical health, that we have to do maintenance, we have to continue to exercise. It's not like we just exercise a bunch and then we're done. No, it's an ongoing practice, and we need people to think about being anti-racist as an ongoing practice, as something that, don't think of it as something that you are going to get good at and be done. Think about it as an ongoing skill to continue to develop. And that's for, people of color too. We have some internalized bias that we also have to work towards. And so it is something for all of us to continue to do is to, work on those muscles around anti-racism and specifically anti-Blackness. But that is a specific request for our white colleagues is we need you to show up and do the work. We need you to really examine in your own lives the ways that white supremacy has been present, that maybe it can be challenging to acknowledge and to, face what, the types of privilege and benefits that you've been able to receive, and to say, what, I benefit from this, and there is more that I can do to leverage that power, to leverage, the people that you can have conversations with, that, rooms that I am not privy to or can't be in, and to bring this analysis into in the ways that, people of color regularly think about race. It is like a filter that you just can't turn off. We need more white people to be recognizing that there is a racial aspect and to use that lens. And again, it may be uncomfortable at first. That's part of the process of becoming anti-racist is figuring out where those discomforts are coming from and working through that, because on the other side of that is where the real growth is. And that's where you can really show up as an ally in this space, is by working through that discomfort and challenging, your peers to work through that discomfort, and challenging yourself to really, when something does feel uncomfortable, examine why is that? Why are you feeling that way? And recognizing that is how white supremacy continues to expand, because it's counting on people to not want to fight back against this discomfort. And that's where folks can stand up. There's lots of really great resources on how to be anti-racist, on how to use a racial analysis in your work, to be thinking about, regularly asking yourself, who is part of this conversation, who has been left out, who is benefiting, who is being disadvantaged, and really, really thinking about those questions on a regular, having that as a regular part of your analysis when you're looking at legislation, when you're looking at policy, when you're looking at research opportunities. How are you examining those specific, where might there be some unintentional bias that is happening, and how are we actively addressing it? Because that's the ongoing work that we need to be doing together.
Absolutely. Benny or Haley, would you like to jump in?
Sure. Thank you, Gerald, for that. And, as a Latina woman, and I appreciate you mentioning this specifically, Gerald, is I, for example, will never understand the lived and embodied experience of any Black person. And that is the point that I want to point out to everyone. As a white person, you will never understand. There is no way. And that acknowledgement is super, super important, because you can't move really without knowing you will never understand. And so how are you engaging in the work? Not to understand, but to actively dismantle the system, right? So that's one point. The other that I wanted to really talk about is the aspect of labor, and labor we ask of, particularly, I would say, Black women and femmes specifically, to be done for us. And I'm using us because I do want to differentiate. And instead of listening and engaging in the work ourselves, I think there's also this fear of, I'm going to mess up. I'm going to make a mistake. You are. You just are. Right? I always like to bring up the fact that perfectionism is a part of white supremacy. Right? And so are we willing to be courageous enough to be like, I am going to mess up and I'm still going to do it? No matter how embarrassing, no matter how guilty I'm going to feel, no matter what, I'm still going to engage in this work. And that's such a beautiful, I think, act to do, because you are going to mess up. We all mess up because we're human. White supremacy is trying to tell us we can never mess up and we have to do things perfectly. We have to do things fast. We can't slow down. Like, that's all of that. The second thing I want to kind of highlight is how to decenter whiteness, essentially, right? So what we saw, I'll rephrase, what I saw and noticed after the draft was leaked in May and then the overturning June 24th is a lot of white women, for example, using coat hanger imagery, and then also either making a mention of The Handmaid's Tale, always as June, or straight up dressing up this way. And I bring these examples because they're concrete examples of centering whiteness, of centering ourselves in these conversations. And it's okay, and I always use this as a therapist, we can hold multiple truths at once. We can hold the fact of, I feel angry, I feel scared, this may impact my life, 10,000% absolutely. And this is going to impact other people even more. I also have privilege, I also have power, right? Like, we can hold both. No one is asking anyone to be like, don't think about yourself. One, that's not possible. Like, no one cares about you. We're not saying that. It's an and. Like, yes, you can be impacted by this. And this is specifically targeted toward Black people, brown people, Indigenous people, trans folks, non-binary folks, non-English speaking people, poor people, right? Like, there's that and is really important, because then we're thinking collectively instead of centering ourselves. And I think when I talked before to your previous question, Regina, of what like working with folks in a mental health space, is a lot of folks felt erased. And again, I cannot speak to the experiences of Black women and femmes or Black people in general in that regard, but I can say from what I have heard, from what I have been privileged enough for someone to tell me, they did feel erased and quite dehumanized, and which typically happens under white supremacy, again, very intentionally, because even then, what is happening is this division instead of a collective of, we are all going to work from the outside margins in. It's like, let me center myself and center whiteness and center white supremacy and do that. And so I think combating that is the key.
Absolutely. So I'm going to try to squeeze in 2 more questions, but this next one might be a little long. So we're going to talk a bit about self-managed abortion. Debbie Billings, a question from the chat. Debbie Billings asked, I want to push back a bit on the idea that we won't see unsafe abortion. Here in the United States, we don't have easy access to medications such as misoprostol. A prescription is needed here when it's available over the counter. In other countries, it's labeled an ulcer medication. So where will people access the medications? How will they access them? And when they can't, what will they use? So I do want to bring in Haley, because I know you had talked a little bit about this, and but I definitely also want to bring in Gerald, because of the work If, When, How has been doing around this is really important to lift up as well. So Haley, let's start with you.
Yeah. So I think there is a very, very common sort of conflation of telehealth medication abortion and self-managed abortion. And these are actually 2 very different things. And this is extremely common for folks to mix this up. And I've been trying to work on how we can further educate the public about this, because it has been a really big problem. Even before Roe fell, Tennessee, where I'm from, made a big show of banning telehealth abortion, which was actually already banned in Tennessee before they did that. So that aside, and people, then believed that they would not be able to self-manage either. So there's this big conflation of the two ideas. So telehealth medication abortion is it's when a patient connects with a provider who is licensed in the state, who either video chats with them, calls with them, texts with them, or sometimes it's just a form and they communicate back and forth. But you're connecting with a licensed clinician who's writing you a prescription for the medication, and then it's either mailed to you or you can go pick it up at the pharmacy. There are a couple different ways this works. That is telehealth medication abortion. Self-managed abortion refers to self-procuring the medications and managing at home yourself. So it often is operating in sort of this legal gray area, which I'm sure Gerald can talk a lot more about. But that is where the criminalization piece comes in. But people do it, and people do it a lot. The research has actually shown that about 7% of, again, women in the United States will self-manage an abortion in their lifetime, and that was before Roe fell. So it is already very common. We're already almost at 1 in 10. So it's very common. That's not to say all of them use medications, but the medications are available from American pharmacies in sort of a extra legal manner. They're available through foreign organizations like APHA, which is based in Austria, and other overseas pharmacies. And they're sold over the counter in Mexico, and often available at flea markets and sometimes at bodegas and things along the border as well. So there are a lot of ways that people are getting the medication, and self-managing, like I said, is not rare necessarily. And that will continue to be available to people because they have been making it work for a long time in a sort of criminalized space. So that is why I say that it's unlikely that we will see a lot of unsafe abortions and that it will be a prominent driver of mortality and morbidity. And again, that's not to say that no people will have an unsafe abortion, absolutely not, but we don't expect on a population level for it to be common. But yes, just to reiterate, a lot of people obtain the pills through extra legal methods, whether that's within the US or outside of the US. And aid access has been really great for that as well, because it's a little bit more regulated than some of the pharmacies that operate in the US in sort of an extra legal space. And those medications have been chemically analyzed and shown to be safe. People have been using them for a long time. We know that people can self-manage their abortions safely and effectively without clinician supervision or clinician involvement. Really, the risk is criminalization. And it always, unfortunately, comes back to that, that the threat of incarceration and the threat of interactions with police, frankly, plays a big role in that criminalization piece. And I, speaking for myself, will come back to something that Benny said, that I think two of the most important things that public health practitioners policy things that public health practitioners can be looking at right now is free and universal healthcare and abolishing police and prisons. It's criminalization, it's access to healthcare. Those are the two things that we really need people to have. They're under threat from criminalization and they can't get quality healthcare. And whether that's abortion or beyond, we want to support the whole person. But these are the two things that we see abortion seekers and people who, are just making reproductive decisions, living their reproductive lives. Those are two of the biggest barriers they have, is that they're being criminalized, poverty is being criminalized, and they're struggling to access quality care. And I think, self-managed abortion comes into that, because even when abortion was legal in all 50 states, we saw plenty of people self-managing their abortions, whether, pills are definitely the safest way to do this and the most effective way to do this. People have also used a variety of other methods, but they're not necessarily safe or effective. But yes, there's a lot of information about self-managed abortion. I definitely recommend Plan C, checking out the website Plan C. If One House website also has a lot of great info about the legal info, but I'll let Gerald do that part. But yes, Plan C is a really great place to get more information. And I just want to quickly say that I think every public health practitioner should understand the protocol for self-managed abortion. So with misoprostol only, it's actually just a very simple 5-step process. A person would dissolve 800 micrograms of misoprostol under their tongue. They would wait 3 hours. They would dissolve another 800 micrograms of misoprostol under their tongue. They would wait 3 hours, and then they would dissolve a third dose of 800 micrograms of misoprostol under the tongue. So that is something that folks really need to know. And the World Health Organization has this protocol. We have an established protocol for self-managed abortion globally. And you can also do it with mifepristone and misoprostol, just as you would do an in-clinic or a telehealth medication abortion. So I can talk forever about self-managed abortion, but I will let Gerald talk about the legal aspects, because it's so important to think about that piece.
I do want to jump in just real quick. I know we're running out of time, so we probably won't get to that second question I was going to ask. But in the public health industry, there is often a conflation of in-clinic healthcare being safe and care and healthcare that's being accessed outside of a clinic being unsafe. And so when we talk about unsafe abortion, we also just need to understand what we're talking about, because there is, as Haley was saying, there is a history in the United States, outside of the United States, of people, self-managing their abortion, and it wasn't even considered an abortion. It was just part of what they did in their communities with midwives and elders. And so as we are in this new era in the United States, we have to really sit with this idea that only in-clinic healthcare is safe. At the same time that we acknowledge, and I did write a piece about this at The Nation, but at the same time that we acknowledge that clinics are needed, public health is, the systems of public health are needed, but that there are instances where, and this is where I will bring in Gerald, to speak about, all of the amazing work if One How has been doing around getting legal information to people when they're in these situations. Gerald?
Yeah, I would say that is one of the things that we definitely saw an increase in since the leak decision, was people wanting to know information about the legality of self-managing their abortions using pills. And part of the challenge right now is that even before this decision came out, there was sort of a hodgepodge of laws. Sometimes it varied, not just state to state, but county to county, about who was going to use what different laws to prosecute people for their pregnancy outcomes, and especially when there was a miscarriage that may be happening, whether that person was believed that was a miscarriage, or if they were being thought of as self-managing their abortions. And again, this is where, I know this was raised earlier, this is really where it's really important for healthcare officials to know that they do not have to, there is no obligation for medical professionals to report a suspected self-managed abortion. That is not a requirement in any state. And so that is where we have seen the most criminalizations happening is a healthcare person reporting someone. And so the legal question is an important one, and it's we do encourage folks to, if they are worried in their state, to contact our helpline, because it's the kind of thing that we do have to kind of look at a case by case. There's no blanket, like we can't blanketly say yes you'll be protected, or yes you'll be at risk. Like it's all at this point, it is all kind of a risk. But one of the things that we do in our trainings, to reiterate to the point that Regina was just making, is that there are a lot of different reasons why why people may choose to do a non-clinic based abortion. And we want to promote that really people should have options. People should have options that if they want a clinic-based abortion, they should be able to get a clinic-based abortion. If they want to self-manage their abortion at home on their own terms, they should be able to do that as well. And there should not be a risk of criminalization for either of those types of abortion. So I know we are at time, so I will leave it there. But please check out our website, ifwhenhow.org, for more information about our helpline for folks who may have those questions, as well as information about our Repro Legal Defense Fund that does provide bail support and other legal support for people who are criminalized for self-managing their abortion or their pregnancy outcomes.
Well, thank you to this wonderful panel. The conversation was so good, my AirPods died, so that's a good time. So thank you all for joining us live today. Just a reminder that this webinar was recorded and will be made available for free by the end of next week. APHA's next 150th anniversary webinar in September will highlight environmental health. All participants of today's event will receive information about upcoming events, and thanks again for joining us.